Good afternoon, ladies and gentlemen. This is O.P. Yadav, CEO-in-Chief Cardiac Surgeon at National Heart Institute and Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery. And we are here in Jaipur at the second annual conference of the Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India. And it's indeed my proud privilege to play host to Dr. Massimo Lemma. Thanks, Dr. Lemma, for being here.
Thank you for asking me to come.
Massimo is head of cardiac surgery at the Jilin Heart Center in China and has traveled all the way to Jaipur after a long journey via Shanghai. So I hope you have recovered.
Thank you.
Massimo, we have been hearing a lot, more ink has been spilled on total arterial revascularization than probably most other facets of coronary artery surgery. And yet we find total arterial revascularization a laggard. So I want two answers from you. Number one, what is total arterial revascularization? And why is it that it is such a laggard?
Very good question. Very good question, because total arterial revascularization, I do believe, is the Rolls Royce of myocardial revascularization. Because, the heart is nourished by coronary arteries, not veins. So if we want to revascularize naturally the heart, you should use arteries. In the end, arteries, respect to the vein, are, let's say, they have the best possibility to keep your job patent for a long time, because arteries, mainly the mammary arteries, are living conduits. So they produce a lot of nitric oxide. We have in our hands what we could call drug-eluting conduits. Like cardiologists have drug-eluting stents, we have drug-eluting conduits. And so if we want to achieve a very good results in long term, we should use coronary artery revascularization. What is complete coronary artery revascularization? If you use only arteries, both mammary, or the mammary and the gastroepiploic artery, or even the gastroepiploic artery, you can achieve complete myocardial revascularization. Why is a laggard?
Let me stop there. Now, suppose I give to all three territories LAD, obtuse marginal, and a PD arterial graft, but to a small obtuse marginal or a ramus or a diagonal, I put a vein. Would you still call it total arterial, or will it fall into the other category?
I would reverse the question. That is, do you really need to graft a small diagonal or obtuse marginal branch? If you need to revascularize it, means that it's not too small, so means that it needs an arterial graft. If it is too small, and so it's not important, you can skip it. So why you want to put a saphenous vein on that small, non-important vessel? So full revascularization means the main target should be revascularized with arterial conduits.
So indirectly you are saying ischemia-driven revascularization, which our cardiologist colleagues have been doing it.
Absolutely.
Okay, and you, why is that a laggard you were asking, you were answering?
Yes, this is the big question. For sure, arterial revascularization is much more technically demanding. Yeah. So in the end, let's say the indication of surgery, the same kind of surgery is not for all the patients, because we should have in our hands a full portfolio of treatment for our patient, but at the same time, that kind of surgery could be not for all cardiac surgeons. Means that being more technically demanding, you should be trained to use arterial graft, so to perform complete arterial revascularization. The problem is that for many years, coronary artery revascularization has been the daily bread of cardiac surgeons. So most probably, in order to keep high volumes, high numbers of patients, we have focused mainly on the numbers and less on the quality. Okay. If we want to reverse this, this topic, we should focus more on quality, so maybe reduce the number, but try to give the patient the ideal solution in order to fix his problem or her problem for the rest of his life.
Well, when we talk of arterial revascularization, and we have been always talking of Lemma to LAD being the gold standard, but there are a couple of recent publications by Samano and Rifault, and even David Taggart has written, is saphenous vein as bad a conduit as we have made it look? Or is it that we have never given a fair deal to it? We don't take saphenous vein with the same rigor as we take a mammary. Always the first surgeon will take a mammary and a trainee surgeon will take the saphenous vein. We don't preserve the saphenous vein well. We don't use the no-touch technique. And then we compare saphenous vein to a circumflex, to a Lemma, to the LAD. So what do you think going forwards? Saphenous vein would have a role to play if properly taken, or you think it is a bad graft and that's it?
I do believe that in terms of research, we should follow all the kind of research that can promise good results. Okay. So in this term, I do believe that it's right to focus more our attention on the treatment of the saphenous vein, either with the external, let's say, waste or, let's say, internal treatment with specific solution that can preserve the endothelium.
Yep.
For sure, the technique is crucial in terms of patency, in the sense that, and probably this is also something on which we skip our attention, because usually the saphenous vein is harvested by the last of the assistant. And so focusing more on the technique of harvesting, no touch technique like we do for the internal thoracic artery, for sure will increase the results in terms of patency. And maybe treating the vein with external vest or biological solution, specific biological solution, we can improve the results of patency. But in the end, we cannot change a vein into an artery.
So if that be so, what is your second arterial conduit of choice?
The second arterial conduit of choice is the radial artery. So the first...
Not the Lemma, not the right internal.
No, the first two at the same level are the Lemma and the Rima. The third, let's say, is the radial artery.
So you believe right internal mammary artery is a better graft than the radial?
Right internal mammary artery has precisely, in my hands, and if you look at the most recent literature, the same results of the right internal thoracic artery, with a few advantages, in the sense that obese patient, patient with chronic gland disease, diabetic patients cannot, let's say, they can have some postoperative complication due to the fact that you have a complete devascularization of the sternum. Even if you harvest the mammary skeletonized, but you have a certain impact on the vascularization of the sternum. So I would say that if there are no contraindication to bilateral mammary harvesting, both EAT harvesting is the best choice, but you can consider also the radial artery as a substitute of the right internal thoracic artery, because in terms of patency you can achieve the same results, and you can offer the patient a less invasive operation, because on the sternum you have less impact in terms of healing.
Well, we conducted a survey, was done it is published in Indian Journal of Thoracic Cardiovascular Surgery, of Indian diaspora as to the reason why they were not using bilateral IMA more often than what they were using. And about 40% plus were scared of using bilateral mammaries for the fear of deep sternal wound infection. Is that what is your experience, or you feel there is no difference?
Not so huge numbers, but in the end, if you consider the possible complications, I would say that yes, at least 20-25% of patients should be, let's say, are best treated using the left internal mammary artery and the radial artery.
Okay. Let me move on a bit. there's been so much of brouhaha about off-pump versus pump surgery. Came in a big way, looked like a definitive disruptive treatment, but somehow we find the so-called Western world is stepping back, but we in India, in Japan, we are still continuing with off-pump surgery with gusto. 60 to 80% of all coronary surgeries in India are off-pump. So my question to you is this a matter of the surgeon doing the operation, or is it really the operation which is at fault?
The operation is not fault.
Operation is not at fault?
No.
Okay.
At all. The problem is that like for total arterial revascularization, off-pump surgery is more technically demanding than on-pump surgery. And it's a completely different kind of surgery. You should be trained on off-pump surgery in order to achieve ideal results. It's a sort of subspecialty, in the sense that the main problem during off-pump surgery is how to keep the patient stable from the hemodynamic point of view. And there is a list of detail and of techniques and tricks that should, or I would say must, be used in order to achieve the perfect hemodynamic stability throughout the surgery.
So is that, if I can stop you there for just a moment, is that the technical aspect, or is it the mindset?
It's the mindset.
It's the mindset.
It's the mindset. Probably that's why in India and in Japan we have 60% of the total patient treated with off-pump surgery, while in Europe it's different.
What about China? What percentage would you be doing off-pump?
Much more than 60% in China currently.
Currently.
Yes.
Okay.
So in the end, coronary surgery, off-pump coronary surgery, is not how you perform the distal anastomosis. That's, the same. You can use the parachute technique either on pump or off pump, but it's not the difference. The difference is how to manage the heart during off pump surgery. When you are on pump, you can squeeze it, you can change the position whenever you want. You don't have to control the hemodynamic stability, you don't have to control bleeding. So these are tricks, or not tricks, these are standard techniques that must be applied in order to go smoothly throughout off-pump surgery. And if
so that brings the role of the anesthetist into the whole...
Yes, sure, the anesthetist is important, but if you, if you consider what has been done during the Ruby trial. The Ruby trial is the trial who has influenced a lot the, let's say, the reputation of pump surgery recently.
Yes.
Unluckily, even if this trial has been published on the New England Journal of Medicine, and recently we have seen the result at 5 years.
5 years, yeah.
Go back and look at the selection criteria of the surgeon of this study.
50 cases.
They were absolute beginner.
Yes. Trainees.
They started from scratch.
Yes.
So sorry, I have to say this, it's unfair, really unfair to run such a study, and it's unfair to publish a study like this in an important magazine like the New England Journal of Medicine.
Okay, yeah.
I know it's a strong statement,
yeah.
But I do believe that it should be completely different if the same study would have been done by consultants devoted to off-pump surgery.
Well, coronary trial came the other way around with more experienced surgeons. Okay, what are your thoughts about an aortic off-pump? This all eggs in one basket and all that kind of a thing. Can the mammary handle all the flow? Can it auto-regulate? So your defining thoughts on this.
Sure. If you combine off-pump surgery with, let's say, no-touch aortic technique, you end up with an aortic surgery. let's go back to the result of the syntax trial.
Yeah.
Syntax trial has been one of the most important prospective randomized multicenter trial comparing surgery to PCI. At 1 year, surgery pays the price of 2.2% of stroke, let's say cerebrovascular accident. If you look at the literature, the cerebrovascular accident, let's say, are between 2% to 6%. And we pay this price within the first 30 days.
Yes.
Because after 5 years, there was no difference between PCI and CABG. So it means that something happened during surgery. And this something is that we treat the aorta not properly, let's say, in the sense that the standard operation is put a cannula in aorta, clamp the aorta at least once,
yes,
maybe twice.
Yeah.
Our patient have diffuse vascular disease, so the ascending aorta can be involved in the disease like the supraortic trunk. And if we clamp the aorta, if you make a hole in the aorta, for sure you can release some debris from the intima that is diseased. So we fix the heart, but in 2%, I would say 2% of our patient, we cause a brain injury. So if we want to, let's say, improve the quality of the result, so reduce the risk of the operation, we should forget the ascending aorta at all. And we can do this, because if you go off pump, and if you use the left internal mammary artery or the right internal mammary artery as the main stream for the blood to the ventricle, you can completely forget the neurological complication after surgery. Why? Now, the problem is, can we trust the left internal mammary artery or the right internal mammary artery in terms of flow? Yes. We have started our experience with Y connection in 2000. We have published many papers. We have studied the blood flow into the Y connection. We have studied the result after 1 year. And we have seen that the mammary artery is a living conduit. This artery can adapt the flow requirements immediately after surgery. So we don't have to be scared by the fact that the mammary has not enough blood for a complete myocardial revascularization.
We debated this 20 years back for left main stenosis.
Sure.
Is mammary enough?
I remember that I was a young surgeon. They told me, don't use the left internal mammary artery when you have a patient with concomitant aortic stenosis, because the left ventricle is hypertrophic and the left mammary artery is not enough to revascularize the left ventricle. So we have changed.
Well, Dr. Lemma, before we let you go, if I were to give you a crystal ball to gaze, what do you see the future of coronary interventions in generic? Let me put surgical as well as medical percutaneous interventions.
Medical, you mean also PCI?
PCI. What is the future? Is these the kind of treatment which are going to stay, or they are just like the truncal vagotomy, gastrogenostomy of 1960s, 70s, which just have vanished?
No. These are two different treatments. So they are both necessary. They are both important. They can really, let's say, using them properly, we can do the best for our patients.
But don't you think they are very poor forms of treatment? They're hardly treatment. They're just gaining, they're not treating the cause. We're just gaining a few years with both of these procedures. So do you think these procedures will stand the test of time? Do you think my children will see these procedures?
Sure, I think so.
You think it's going to be there 50 years down the line?
Yeah, down the line, and most probably we will see a merging of these two procedures.
Oh.
In terms of hybrid revascularization.
Okay.
So if I can add a comment, the two procedures, they address differently the issue, in the sense that coronary angioplasty goes directly on the stenosis, coronary artery bypass go after the stenosis. So that's why coronary artery bypass is going to last longer than PCI. But PCI has the importance in a subset of patients, very high-risk patient, very elderly patient that cannot be treated by so far with cabbage can have an improvement of their situation using PCI. So, I mean, it's an evolving process of myocardial revascularization. And having in our hands both these technologies and techniques and merging them properly, for sure we will be able to improve the quality of the result for the ischemic population.
Well, ladies and gentlemen, we have heard the views of Dr. Lemma. He backs strongly for total arterial revascularization, feels both memories and radial should be used and every effort should be made to give arterial revascularization. He also backs for off-pump surgery. He feels it's the mindset which is boggling the specialty and it's not the surgery itself. He also backs for anaortic procedures. And looking forward, he feels both percutaneous interventions and bypass surgery will continue to be available maybe 50 years down the line, and that's where I differ from him. Massimo, you are younger than me. You will be alive to see. But when you see I come through, do remember me. I might have moved on to the next world. I feel better options have to come. Whether they're going to be molecular biology which will change, or is it the cellular options, genetic engineering, but our mechanical options to coronary artery disease, 20 years is what I give them. Let's see if I'm alive to face Massimo again. Thanks a lot for being with us.
Thanks a lot.